Hello and welcome back. A long time coming to the Compliance for the Sake of the Patient. Man, we're glad to be back in your ears and back on video here on YouTube for the very first time. I'm John Mitchell and I am back, baby, and we are ready to go with Compliance for the Sake of the Patient again. I'm here with Steve Sponbrook, as always. Steve's good to see you.
Good to see you, John. I apologize for making everybody see our faces after all these years, but party time.
We're going out to YouTube, man. It's going to be fun. So we've got lots of places that we're going to be pushing out content now here in 2023 and beyond. So stay tuned for YouTube, for definitely our Accreditation Readiness Network. Those of you who are members of the ARN are going to get some video and audio as well. So we're really excited about that. We're also excited to bring on one of our latest team members today, Edwin, who is a longtime friend of yours, Steve. So I'm not going to get in you guys' way. I'm going to introduce Steve and Edwin and let you guys get on with what I think is going to be an awesome topic.
Yeah, well, thanks, John. It's been almost 2 years, so we're long overdue for getting us back out there. Apologize for that. We just kind of got distracted doing some other things, but a lot of exciting stuff happening at MSL. One of the most exciting things, I think, is having Edwin join us, which is sort of a shift in focus, frankly. Back when we first started Compliance for the Sake of the Patient, it was all about life safety, environment of care, and still going to be very focused on all of those things. But that's because that's all MSL had been doing up until that point. Well, back in 2022, we got into the clinical business and added that component to really help solidify our mission in trying to improve patient safety and reduce the risk to patients in our healthcare organizations. And so having Edwin join us is a major step in that direction. And I'm going to put him a little bit on the spot. Edwin and I go way, way back we went to high school together, grew up in the same town. I won't tell you when that was, but Ronald Reagan was in the White House. I might give you a little bit of a hint there. And I was thinking about it earlier today. I was like, I wonder if someone had come up to you and I, Edwin, back when we were at, let's just call it one of the weekend night high school fellowship events. That's a good way to put it in. And said, yeah, there you go. One day you guys are going to partner on improving patient safety in healthcare organizations. What our response would have been. I probably would have laughed them right out of wherever it was we were, but amazing how life changes. So welcome aboard, Edwin. And like I said, we go way back. Edwin recently is retired from Parrish Medical Center down in Florida. And I'll let you do a little bit of an introduction to yourself. And then I've got some questions I want to ask you, if that's okay.
Right. Very good. Well, Steve, I appreciate it. John, thanks for the setup as well. Steve and I go back quite a bit, beginning in Eastern North Carolina. I am a registered nurse by training. When I left high school and left Steve, I went off to become an engineer. My first stint at college was a great life learning experience. It did nothing for my academics. So I went back home and recentered myself. And my mother, who was a lab technologist, introduced me to a gentleman by the name of Theodore Koljeski, Mr. K. He was the chief nursing officer at the local hospital. And he allowed me to start working there as an orderly. And since then, I have been in hospitals for quite a few years since then. As Steve just referenced, I recently retired from Parrish Medical Center in Titusville, Florida, where I was the senior vice president of integrated and acute care and the chief nursing officer. In addition to nursing in general, I had responsibilities for all of our accreditation readiness, CMS, AUG, Joint Commission. Parrish Medical Center, through my work with the Joint Commission in 2016, was the first and is still the only hospital in the nation to be certified in integrated care. And that really comes to the point of what we're going to be talking about in the podcast today, is that it centers around zero harm, making sure no matter where in healthcare a person is journeying, whether it be through the primary care office, through a skilled nursing facility, home health, or an acute care facility, we have the information in front of us to assure that we do not give the wrong medication, that we do not attempt to do the wrong procedure, that we are working in unison for one purpose and one purpose only, and that is to partner with the person we have the honor to partner in care with.
That's awesome. That's a great introduction too. And so it's interesting how our paths sort of crossed and recrossed ever since high school. First down at Carteret Healthcare when you were there and you were working in the emergency department. And I was pretty new in my business back in those days. Actually, I was still working for Premier. Anyway, it's just been amazing how we've just kind of grown on parallel paths with the same passion. And frankly, it's that passion that's kept us connected. And it's a true story. I think it was a Saturday night. I was sitting upstairs in my little media room and had my laptop open with Facebook up, and I get a message from Edwin saying, "Hey, I'm thinking about retiring. Is there room for me with you guys?" And I'm like, "Well, heck yeah, let's make that happen." And that was just a couple of months ago. But a couple of things I wanted to ask you, because you do have a PhD in nursing, which is kind of rare, frankly. But you didn't do that, 20, 30 years ago. You did that fairly recently, right? I mean, what was it, about 5 years ago?
Yeah, I actually ended up doing what I've termed as the 15-year plan. I got my bachelor's, and then 15 years later, I went back. I got my bachelor's from Atlantic Christian College, it's Barton College in Wilson, North Carolina now, and then went back for my master's in business, my MBA at East Carolina University. And then 15 years later, in 2016, went to University of Central Florida, UCF, and I have attained my doctorate in nursing practice executive leadership. Did it for several reasons. One is I am a lifelong learner, and I promoted that with my clinical staff at the hospital and felt that it was very important that I only not talk the talk, but I walk it as well. And so if I'm going to expect other nursing leaders to continue their education, I need to take the opportunity for me as well. In addition, at the same time, I had joined an organization, a not-for-profit organization, the Patient Safety Movement Foundation, and was looking for ways to not only deploy some of their practices, but also look at what we were doing, what's happening locally. And I really believe that through the doctoral preparation, learning to read for content, learning to read for bias, I was actually able to put together a capstone project that has been published in a peer review magazine, and it is Zero Harm in Transitions from the ED to Med-Surg. And by deploying that at my local hospital, we took what was one of the higher areas of problems and patient harm, which is transitions in care, and we have all but eliminated any harm occurring in that transition from the ED to Med-Surg. We don't have med errors anymore. We don't have missed orders anymore. We have the warm handoff so that the person is greeted by the nurse who has been caring for them in a soft handover to the nurse who is going to be caring for them. And the three of them together sort of confirm what the plan of care is going to be. And that's been very successful. So through doing the doctoral program, it allowed us to further our focus on zero harm.
That's remarkable. And I tell this story all the time about when I first visited you down in Titusville, and I was down there in another client in Orlando, and had some free time, and Edwin was gracious enough to give me a little bit of his time to talk about the patient safety movement. You were the one that introduced me. You were making posts, I think, on both Facebook and LinkedIn about it. I'm like, what's this all about? I want to hear about it. And MSL ultimately made a commitment to the patient safety movement, which is a letter I still have behind me. But I went down to talk to you about it. And so we were in your conference room in the executive suite of the hospital. And a lot of people know this about me. I'm an avid amateur photographer. I'm not very good at it, but that's what I like to do. So I'm really interested in images, and you had some really cool photographs in there, and I'm looking at it. I'm like, wow, that's an interesting photograph. And I asked you a question. I'll never forget. It was about a young guy, and he was wearing the parachute garb or, skydiving stuff, doing the thumbs up, I'm like, wow, it's an interesting photograph, and you told me the story, which I'm going to let you tell the story because I'm sure you tell it better than I do. But in fact, why don't you tell us a story about that young man?
So well, let me sort of back up with that. In that conference room, it was my think tank. So not only do we have the 4 pictures of people, but we had a lot of numbers on the wall, a lot of our accreditation reporting. And again, it just, anywhere you turn in that room, it gives you a focus on healthcare and person-centeredness. But what that was is on the end wall, which is a dry erase wall, I've got the term never again written, and there's 4 pictures around there. And the never again is our commitment to never killing another person that we have the honor to partner and care with. And there are actually 4 pictures up there. And I'm going to add to this, Steve, because it does bring value to those 4 pictures. About 10 years ago, 6, 7 years ago, CMS, the Centers for Medicare and Medicaid Services, and then VHA were partnering in looking at patient family advisory councils across the nation and who was doing it well, who was engaging the families in developing the plans of care. They did phone interviews of about 100 hospitals, and they chose 10 hospitals to come visit, Parish Medical Center being one of them. So 3 people came on site, and on that Wednesday morning, a gentleman is sitting across the table from me, a gentleman is sitting next to me, and a female partner is sitting to the left of me. And we're talking about patient family advisory groups, committees for quite some time. And I can't remember exactly why, but the gentleman across the table from me turned and saw those 4 pictures and says, please tell me, what is this? And so I did. I said, well, at your 9 o'clock position is Sebastian Ferrara. Sebastian was a 7-year-old kid in South Florida who healthcare was providing care for, but we killed him with an overdose of medication, a concentration that was 100 times greater than what was ordered. On the top is a picture that many people in healthcare have known for years. It is of Josie King. I've had the honor in the past of meeting Josie's mom, Sorrel King. Josie was a 3-year-old little girl who got burned in hot water in a bathtub, had to spend a couple of days in pediatric ICU, and came out. And she too was killed with a lethal overdose of a medication of higher concentration than what should be. Sorrel King has become infamous for her book, Josie's Story, and promoting the patient safety focus. At the 3 o'clock hour was Josh Barron. Josh, and some people will know his story as well, a little guy who he and his family were on the way home from a summer vacation in the beaches of Alabama. They come around a curve in a 2-lane road. 18-wheeler hits them. His mom and a sibling are instantly killed. He is flown to a trauma center. Is in recovery a little bit, still in the trauma unit, and the trauma surgeon tells Dad, if you need to go home, I understand it. You've got a couple of funerals to plan for. We got Josh stabilized. As soon as Dad gets home, he's called back to the hospital, and Josh has died from an overdose, overconcentration of medication. And then the gentleman in the 6 o'clock hour is who Steve was referring to, and this is Josh Nahum. And Josh did not die when he jumped out of a perfectly good airplane with a parachute that did not open. He died because of sepsis from dirty instrument used in his brain surgery. So as I tell that story, the gentleman across the table from me, Marty, leans toward me a little bit and says, Edwin, you do realize that Josh's father, Armando, is sitting to your right. And so that formed quite the friendship. Armando Nahum, I consider a very good friend now. He is an instrumental member of 2 things. One, of the Patient Safety Movement Foundation, but also another organization that he has engaged me in joining very recently. And this is actually a drive from the World Health Organization, and it is Patients for Patient Safety, PFPS. And again, I would encourage everybody in healthcare to take a look at that. Members, ambassadors of the PFPS are patients, they are clinicians, they're engineers. It is people who understand our obligation to get to zero harm.
It was interesting that you mentioned the World Health Organization, because a couple of months ago, a friend of mine from Canada who knows my passion sent me a link and said, you probably want to do this webinar. You'll have to get up pretty early, because it was like way early in the morning. But it was the World Health Organization's, I think it was the titles and like the patient's perspective or the family perspective or whatever it was, but it was their zero harm. But there was remarkable to me was there was only, I think there were 54 people that showed up for this thing. And like 4 of them were people that were involved in actually giving it. And I thought, gee, what I came away from that was where we've been estimating about roughly 200,000 deaths per year in the United States due to preventable medical harm. They're estimating closer to 400,000. So where there was this distant gap between the two, 1 and 2 causes, which, cardiac arrest or heart disease and cancer, that gap closed. If their estimates are correct, then that gap is much closer than we even ever believed before. So, you mentioned that, and it just kind of struck a nerve with me. I was having a discussion just last week with another colleague about access to care and patients' expectations, regardless of where you were. And I shared a story with him. I said, I had the opportunity to teach for about 20 years to construction companies. And one of the things that I would ask them would be, think about the hospital you're going to go to, the hospital that you may take your loved one to, not the one you're working in currently, but your hospital. And I put up like 10 things on the screen. I said, what are your expectations? And they were all like, best in care, best technology available, will make my situation better, will do no harm. And of course, every time I got 100% for all those responses. And it just reinforced what I already knew. And it's like, having lived that patient experience myself back, granted, it was a long time ago, everything else, you don't think about all of the challenges that are faced by organizations, whether it's financial process, FTE shortage, any of that, none of that matters. When you're in the moment, when you're the patient, all you're worried about is, I need help. And for the most part, you don't even think about the amount of trust. I mean, we talk about trust when you get on an airplane, and the door closes and the 2 people up front and the amount of trust you put in them. I would say that's rivaled, if not even surpassed, by the trust we put into healthcare providers. Right. And typically that's not a choice. It's something that just sort of happens. So we obviously are kind of have a kindred spirit in that. And I was excited about you telling that story because that left a lasting impression on me, and I've shared it. You didn't share the last part with me when we were there, so I'm glad to hear that part. I'll be ripping that part off from now on as well. But relative to patient safety, because that's really what our mission's all about, and why we're so excited to have you and the other clinical people on our team and our other clinical partners engaged and doing some of the other stuff that we're doing, like the ARN, because we feel like we can get the message out faster and more accurately than we've ever been able to in the past. But, when we framed up the original size of the problem back in 2019 with the very first episode of this podcast, none of us would have thought in a year, we were going to be facing this global pandemic. Although all the infection preventionists that I was talking to down at APIC a couple of weeks ago, they were all telling us it was coming. They didn't tell us it was coming in March of 2020, but they were telling us it was coming. So kudos to them. But, I want to get your opinion on how the pandemic impacted our pathway and our goal of reducing preventable harm. Because from my own perspective, and it may be an ignorant one, frankly, it feels like it in some ways it's helped. In other ways, it's created some barriers for us, particularly early on when we just got, and obviously wasn't on the front lines. You were, but when everything just shifted to caring for these people, really, really sick people, it was growing exponentially. So what are your thoughts about that?
Steve, I completely agree. Being the senior vice president and CNO, I was also the incident commander for our pandemic approach for 3 years. Now, I've been incident commander in disasters my entire career, 3 days for Hurricane 1, 3 days for Hurricane 2, for a plywood factory that explodes in Beaufort. But I had never planned to be an incident commander for 3 years. And at Parish Medical Center, we have a very flat structure. So you're very right. Not only was I responsible for the strategic approach to the pandemic, along with many other very smarter than me people, but also we're directly involved in the care. And my observations, and I've studied this for a few months now, have been on both sides of the coin. The disruption that healthcare has seen is unmeasurable, and I'm not sure we'll ever be able to get a true measure on it. And when I'm talking about the disruption, I'm talking about the disruption of healthcare providers, nurses, respiratory therapists, physicians, who for whatever reason, some of them burnt out with the intensity of what was going on. Some of them left for the glory of the dollar. Let's be honest here. And it disrupted health systems. We lost almost our entire respiratory therapy department, and we lost probably 50 nurses throughout the pandemic. And again, some
went to travel.
Yeah, some went to travel. Some stepped away. Now, one of the good things, and this is on the positive side, we kept in contact with those of our care partners, nurses, who stepped away because of the intensity of what they were being faced with and just needed a break from healthcare. We've kept in contact with, and I have re-engaged with about 10 to 12 nurses and have come back into the hospital. Half of them back into their original departments, half of them into other departments. That's fine. They're back at the bedside. They're good nurses. They're good people. They're good therapists. For an example of the impact of the intensity, most med-surg nurses, they will work many shifts, and they may have one code blue a year, every couple of years, have a patient die unexpectedly on them, and a couple of 3 times, for a couple of years. In the ICU, it's a little bit more frequently. In the ED, it's a little bit more frequently. In our ICU, we have a 12-bed ICU, and in the August and September timeframe of 2021, we had over 65 deaths, multiple a shift. I've talked to veterans of wars, and they didn't see that type of impact. There was one day that I was looking at it and seeing what was going on. I was looking at the ventilator count. I was looking at the acuity of our patients, and I knew that our 4-bay morgue was not enough. And I was able to find a refrigerated trailer truck and brought it in and spent 2 days along with one of my other directors. He's a fairly hefty guy, a strong guy. And he and I spent those 2 days respectfully moving body after body after body without stacking them on top of each other, and we ran out of room. Wow. So coming back to the main point, there's been a huge disruption in healthcare, and in the teams that have been built over the years in the trust. Again, we still have high numbers of agency staff, so some of them are in it for the money, some of them are in it to care, but there's a disruption in the teams. On the positive side, because of that 3-year focus, I've seen many people, especially at my organization and a few other Vizient organizations, who have committed to coming together and looking at those processes and protocols and making sure that we are doing the safest thing we can for the patient. One of the very positives that I've seen come out of it is, and in Florida, Governor DeSantis put this into law. It shouldn't have to be a law, but it's where it is. We learned the value of the family and the care of the person. And when we went through those months and months and months, and by federal mandate, you could not allow them to visit their loved one. That's just not right. We started very early a video program using FaceTime so that no one ever dies alone. We made sure that a family member, if they could not be there in person, was there in visual, in auditory, in some way connected with them every single time. And that's where healthcare has to commit to making sure that we understand the value of the friend, the family, whoever the family is as defined by the person within that. We have learned how to fast track changes. Back to your point, from an engineering standpoint, I re-engineered negative pressure rooms 5 times in those 3 years. And we learned as we went. The partnership that I had with my plant engineer He reported to me, but it was a true partnership between he and I in bouncing ideas off of each other. Of how do we get the 6 exchanges in the room every 10 minutes and still make sure that the nurse can get in and out of the door without being trapped in the door for an hour and a half and not being able to talk to anybody else. It's a lot of innovations came out from that, and I look forward to seeing those innovations grow as we continue to emerge from the pandemic.
Yeah, I think there's been a lot of interesting things that have come out of that for sure. And I applaud you guys for your efforts to make sure that the families were there. This is a little personal for me, but two of my dearest, closest, lifelong best friends passed away in the summer of 2020, both from cancer, one of them a brain tumor, one of them lymphoma. And we weren't able to really be with them at all. One of them was able to be outside, through a screen window because he was actually in a hospice. He'd been moved to a hospice center. Yeah, I don't, and I can contrast that when I was in the hospital for 4.5 months, these guys were there almost every day supporting me. And you cannot overstate the importance of having just someone there that makes you feel good being there.
Yep. Absolutely.
You just cannot overstate that. So I didn't know we were going to go down that road today, but that's a remarkable thing. It's interesting. I do see some of the positives, and it's a little close to home connection here. And I put this in both an ARN post and in our internal post yesterday, that we had some tornadoes a couple of days ago that went through here, and one of them hit the Pfizer plant in Nash County and really did a number on it. I did not realize until reading the day after that 25% of all the sterile injectables for the country come from that one plant. Right. And that like 50,000 pallet loads of that stuff got wiped out. Interesting though, I've got some responses that, hey, one thing we learned in the pandemic is how to be creative and getting the supplies we need, securing split. So it's like, yeah, well, it wasn't all bad. Certainly wasn't all good. Right. I can tell you from what I've been hearing from all the people I talked to about the whole teamwork disruption, and that's a really good way to put it. Teamwork disruption, that is industry wide. And on the flip side of that, the core groups that have stayed, those teams have functioned, and the relationships have been like never before. Mm-hmm. And from a facilities perspective, I think it's been remarkable, honestly, that now we all, not that we didn't get it before, but we totally get that we're part of the care team and how important it is. And I think there was some eye-opening that happened between on both sides of that fence, between facilities and clinical, seeing how difficult each other's lives and jobs were during the pandemic. And it was just like any other traumatic experience. There was some bonding that came from it. But,
one of those other examples, not just engineering and clinical, but clinical including pharmacy and others, we were very fortunate when the vaccines started becoming available. I reached out early and had our storeroom reach out to find out if we could get a deep freezer, a ultra deep freezer, and we were able to find one. So the partnership between pharmacy, clinical engineering, nursing, the distribution logistics that had to come through together to make sure that drug was maintained at that ultra cold temperature until 10 minutes before administration to the patient, and the process to go there. To your point, Steve, the collaboration across the organization is worth listening to, worth making sure we don't forget.
Yeah, and so that it's almost like you read my mind, because what I was about to say was what we want to do is, if we can, if it's not too late, is continue this momentum that we created with this camaraderie and this focus on doing what's right for the patient, and now take that off focus of pandemic response and focus it on improving patient safety and being in compliance for the sake of the patient, which is what we've been talking about all along. We hadn't talked a lot about compliance today, which is fine. It's not always about that. It's more, for us, it's always been about trying to do what's best for the patients. And, I've heard so many horror stories recently of people who've had outcomes that were contributed to by either mistakes or whatever, including some dear friends. And it's just like, wow, we've got so much left to do, and it's, I'm just excited that you and the other clinical people are joining this effort, and I'm excited about what I think we can accomplish going forward. And being down, I got to tell you, I'll brag on my infection prevention colleagues. We went to APIC 2 weeks ago and spoke there on ventilation systems, and just the passion, the energy and excitement there was incredible. My colleague Gordon Burrell, who's been a previous guest on this podcast, he and I spoke together. We every day we were like, this is just remarkable. It's just, we've never felt so much energy. I really expected them to be just beat up. They were just like worn out, just because they've had a rough 3 years. But quite the opposite. So I came away from that really feeling inspired that it's time for us. There's a lot left in the tank, and we can do this if we set our minds to it. So I think now's probably as good a time as any to kind of wrap this discussion up. But if you've got anything else that you want to add in terms of what would your estimation be? And would you agree with the World Health Organization that we're probably way up there in the hundreds of thousands?
I do, because many times in counting the harm in the healthcare industry has always been around acute care. We have not counted what happens when Mr. Johnson sees physician A, gets a prescription, goes to physician B, gets a different prescription, goes to physician C, gets a third prescription, or maybe a 23rd prescription, and somewhere in there is a bad impact of medication management, and the person dies because they're 86 years old. Well, historically, we haven't applied that to healthcare errors, but it is much of an healthcare error at that level as it is in the wrong site surgery. So as we look at across the continuum, as we look at integration of health systems, that's where we've got to take a look at. It's not just in the four walls of the hospital. It is within the borders of this country and of the world.
Oh, absolutely. I wasn't chuckling because I thought what you were saying was funny, but a little personal experience. So recently I went through some health challenges of my own, and I have 2 different care teams right now going on. And one of the responses was to put me on a antibiotic that I was on, and I got so sick, couldn't figure out what was going on, was talking with them. They're like, well, just hang in there and we'll get it better, we promise. Well, I finally, on day 12 of a 14-day cycle, found a website on drug interactions and started putting in another medication that another physician had prescribed for me. And guess what? Those 2 had major interactions that were causing all my problems. Mm-hmm. I was like, well, holy moly. When you start talking about how many degrees of separation there are between you and a medical error, I don't have to look real far.
The old adage is true as well. Before my father died in 2009, he had heart failure. And one of the episodes where he came out of the hospital, he was ordered some more medications. And I remember getting Dad home that night at Mossy Oaks, and my brother-in-law, who is an anesthesiologist, my sister, who is a neonatal nurse, and myself spent 3.5 hours trying to decipher the 2 shoeboxes of medications that he was taking. And
oh my gosh.
The interactions, the contraindications, the duplications of the same medications were just phenomenal. And I think about what somebody who has no exposure to healthcare and they're given all of this, what resources, and this comes back to our continual readiness. How can we not only help the healthcare professionals, but how can we talk plain language and bring the patient, the family, and the community to the conversation so they're part of the solution, not just writing the letter to the editor?
funny that you mentioned that, because John will remember about 10 years ago plus when I messaged him one day after having this, like, literally sitting in church, came up with this idea of we must.org, and came home, registered the domain. We never really did anything with it for a long, mainly because we determined that's what MSL ought to be about. But part of what the vision for that was educating not only care providers, but also patients and families about what to be, what to look for. It's like,
Yep.
I hate to say it, but I would never recommend someone go to the hospital without an advocate that's a knowledgeable advocate.
Absolutely.
And it's because we're completely overworking our teams. I mean, you talked about it when you talked about how difficult it was to keep people during the pandemic. And I perfectly understand that. And having spent some time in the hospital with my friend with a brain tumor before he passed away, I saw that firsthand. And I also saw the culture within the culture. It's like, because I know the leadership people at the hospital, I know what they think. And I've had the conversation with, it's like, this is what you think, but this is what I saw at 2 a.m. Right. And this is what I heard, because they were very open with what was going on. So it was interesting. Well, I'm just so excited to have you. I'm excited to be back with the podcast, John. I don't know, we probably went a little longer than you hoped on this one, but I'm sure you can make it work.
No, we love it. Love it being organic. And I was just sitting here thinking, I'm so thankful for smart people like both of you, that are advocates for those who aren't. My in-laws both passed away in 2020 in a nursing home. And we watched them pass away through a window, and in the moment felt there was no advocacy. And it was hard on us. I can't imagine what it was like for our in-laws. We still talk about it. And I'm just thankful that, Edwin, I'm thankful you're not playing golf somewhere. I'm thankful that you aren't retiring and going off into the sunset, because you certainly deserve to. With all the hard work, all the effort you've put in, what I'm most honored to be a part of Compliance for the Sake of the Patient, and the effort that we're trying to pull off here, is that guys like Edwin, who have given their life to this thing, aren't done. And I think more than ever have decided, hey, I've still got something to say, and I got something to do. And man, welcome to the team. We're honored to have you, Edwin.
Thank you very much.
Here's one that Edwin might relate to. That it's the third week in July that I'm both thankful that neither one of us are out picking tobacco right now. You remember those days?
I remember them well.
Yeah, the Eastern North Carolina thing, being in the tobacco fields in the summertime. Summers were short down here, so.
Well, Edwin, thank you so much for your time. Steve, it was great as always. And those of you who are listening, hang in there, man. We are going to continue the ride of Compliance for the Sake of the Patient. We got lots of things planned, and we can't wait for what's next. Thanks for listening, and we'll see you next time.